Manual, semi-automated, and point-of-care testing in hematology. So manual cell counts. So the primary equipment that is used for a manual cell count is the hemocytometer. This device is essential for performing accurate manual counts of blood cells when automated counts are unavailable or when precise control is needed. A hemocytometer consists of a specialized glass slide with a grid etched into its surface. This is designed to hold a specific volume of fluid for counting. The standard counting chamber allows for counting cells within a defined area in depth, enabling calculation of cell concentration per unit volume. The function of the hemocytometer is to facilitate the manual counting of cells such as red blood cells, white blood cells, or platelets under a microscope. The counts are used to estimate the concentration of cells in the blood or other body fluids. Regarding dimensions, the counting chamber typically has a depth of 0.1 millimeters in a grid pattern of 3 millimeter by 3 millimeter squares of known size, allowing for precise volume measurement during counting. When performing a manual cell count using a hemocytometer, specific sections of the grid are designed for counting different cell types. For the white blood cells, these are counted in one area of the chamber, where the red blood cells are counted in another designated section. So a crucial technique to ensure accuracy is the top left rule. So cells that touch the top and left boundaries of the counting squares are included in the count, while cells that touch the bottom and right boundaries are actually excluded from the count. This prevents double counting of cells located on the boundary lines. There is a video on how to actually calculate this formula. So if you're in my class, it will be on the next slide. For hemoglobin determinations, we use the cyan-met hemoglobin method. The cyan-met hemoglobin method is the reference range for hemoglobin determination, which is approved by the Clinical and Laboratory Standards Institute, or the CLSI. This method is based on the conversion of hemoglobin in blood to a stable cyan-met hemoglobin complex. When blood is mixed with a reagent containing potassium cyanide and potassium ferricyanide, hemoglobin is oxidized and combines with cyanide ions to form cyan-met hemoglobin, which has a characteristic absorption peak. For calculations, the hemoglobin concentration is determined by measuring the absorbance of the cyan-met hemoglobin solution at a wavelength of 540 nanometers using a spectrophotometer. A standard curve is created by preparing dilutions of a commercially available cyan-met hemoglobin standard according to the procedure. Absorbance readings of these standards are plotted against their known hemoglobin concentrations or percent transmittance. The hemoglobin concentration in the patient sample is then calculated by comparing its absorbance value to this standard curve. Errors in hemoglobin measurement using the cyan-met hemoglobin method can arise from improper specimen handling, inaccurate reagent preparation, or incorrect spectrophotometer calibration. Turbidity or lipemia in the blood samples may also interfere with absorbance readings, which could lead to inaccurate results. There are several alternative methods that have been developed to overcome the limitations of the cyan-met hemoglobin method. First one we'll talk about is the HemoQ. So this is a portable device that converts hemoglobin to azidomethemoglobin and measures absorbance photometrically at two wavelengths, at 570 nanometers and 880 nanometers. This dual wavelength reading minimizes interference from sample turbidity and eliminates the need for specimen dilution, which makes it useful for point-of-care testing. And then we have the sodium lauryl sulfate method. In this method, hemoglobin is converted to SLS methemoglobin, which is a stable complex that can be measured spectrophotometrically. A major advantage is that it does not generate toxic waste, unlike the cyan-met hemoglobin method, which actually uses cyanide. A manual hematocrit measurement requires basic laboratory equipment, including a centrifuge that is capable of spinning a microcapillary tube at high speed and a microhematocrit reader to measure the packed red blood cell volume. For the procedure, the blood is collected into a heparinized capillary tube, which is then sealed at one end with clay or sealing compound. The tube is placed in the centrifuge and spun at a specified speed, which is usually around 10,000 to 12,000 rotations per minute, for about 5 minutes. This process separates the blood into layers, with packed red blood cells at the bottom, a thin buffy coat of white blood cells and platelets in the middle, and then plasma on the top. After the centrifugation, the microhematocrit reader is used to measure the proportion of the tube that's occupied by the packed red blood cells. This value is expressed as a percentage of the total blood volume represents the hematocrit. There are some sources of error in this though, so some potential errors in the manual hematocrit determination can include improper sealing of the capillary tubes, which can cause a leak, inadequate centrifugation time or speed, which can lead to incomplete separation, and misreading the buffy coat layer as part of the red cell volume. Additionally, hemolysis or excessive plasma trapped between red blood cells can falsely lower the hematocrit reading. The rule of three. All right, so this is a useful clinical rule that applies to specimens with normocytic, normochromic red blood cells, where the hematocrit value is expected to be approximately 3 times the hemoglobin concentration with a small allowable variable. The formula is found there on the slide, so you would take the hemoglobin that you get, multiply that by 3, and that should be about what the hematocrit level is, plus or minus 3. So it is a good practice for laboratory technologists to mentally multiply the hemoglobin value by 3 for every specimen, and this just does a really quick check. Significant discrepancies from this rule may indicate the presence of abnormal red blood cells, such as microcytosis or macrocytosis, or could serve as the first indication of an analytical or procedure error. So failure of this rule could indicate abnormality in red blood cells, like mentioned earlier, also sickle cells. Hematologic indices such as the mean corpuscular volume, the MCV, the mean corpuscular hemoglobin, which is the MCH, and the mean corpuscular hemoglobin concentration, or the MCHC, are valuable in clinical practice for several reasons. They help determine the average volume and hemoglobin content and concentration of the red blood cells, which can help provide insight into the nature of anemias and other blood disorders. These indices also serve as quality control checks by allowing laboratory personnel to identify inconsistencies or errors in test results. Additionally, hematologic indices are commonly used in the initial classification of anemia. So, for example, distinguishing between microcytic, normocytic, and macrocytic anemia, this helps to guide further diagnostic workup and treatment decisions. For MCV, or the mean cell volume, this measures the average volume of individual red blood cells and is expressed as femtoliters, or FL. For the calculation, it is right there, and there's a little example, so go ahead and take a look at that. But for the reference range, the normal reference range for MCV is 80 to 100 femtoliters. Values below this range indicate microcytosis, or small red blood cells, while values above the normal range can suggest macrocytosis, or large red blood cells. So MCV is very important in classifying anemias. For the MCH, or the mean cell hemoglobin, this measures the average amount of hemoglobin contained in a single red blood cell and is expressed as picograms per cell. For the calculation, once again, it is listed there on the slide, so take a look at that. For the reference range, the normal reference range for MCH is 27 to 31 picograms per cell. Values below this range can indicate hypochromia, which is less hemoglobin per cell, which is often seen in microcytic anemias like thalassemia and iron deficiency anemia. For MCHC, or mean cell hemoglobin concentration, this measures the average concentration of hemoglobin in a given volume of packed red blood cells and is expressed as grams per deciliter. For the calculation, once again, it is on your slide, so take a look at that. For reference range, the normal reference range is 32 to 36 grams per deciliter. Values below this range can indicate hyperchromia, which is a decreased hemoglobin concentration in the red blood cells, whereas values above this range could suggest spherocytosis or other conditions with hyperchromic cells. When performing a white blood cell count manually, if 5 or more nucleated red blood cells, or NRBCs, are observed per 100 white blood cells in the peripheral blood smear, you must perform a corrected white blood cell count. This correction is necessary because the NRBCs can mistakenly be counted as white blood cells by the automated analyzers, which could lead to an overestimation of the actual white blood cell count. So the corrected white blood cell count is calculated using the formula shown on the slide. This adjustment provides a more accurate measurement of the true white blood cell count. For the reticulocyte count, this is used to assess the erythropoietic activity of the bone marrow, which can help to evaluate bone marrow response in various anemias and other hematologic conditions. So the principle of the test is the whole blood is anticoagulated with the EDTA. It is stained with a supravital stain, such as new methylene blue. The reticulocytes are defined as non-nucleated red blood cells that contain 2 or more particles of blue-stained granulofilamentous material after staining. These blue particles represent residual RNA and organelles in immature red blood cells. For reporting, we report an absolute reticulocyte count. This is the total number of reticulocytes in a given volume of blood. The corrected reticulocyte count adjusts the reticulocyte percentage based on the patient's hematocrit to account for anemia. Then we have the reticulocyte production index, or the RPI. This further corrects for the premature release of reticulocytes from the bone marrow by considering their maturation time in circulation, providing a more accurate measure of marrow response. For the absolute reticulocyte count calculation, this represents the total number of reticulocytes that are present in a given volume of blood. It is calculated using the following formula found on your slide once again, where reticulocyte percent is the percentage of reticulocytes observed in the stained blood smear, and the red blood cell count is expressed in millions per microliter or trillions per liter. This value helps quantify the bone marrow's production of new red cells. We can do a corrected reticulocyte count. So in specimens with a low hematocrit, the percentage of reticulocytes may appear falsely elevated because the blood contains fewer red blood cells overall. To account for this, a correction factor is applied using the average normal hematocrit value, which is considered to be 45%. Once again, the calculation is found on your slide, so take a look at that. And this adjustment provides a more accurate estimate of reticulocyte production relative to the patient's anemia status. For the reticulocyte production index, this further adjusts the corrected reticulocyte count to account for the fact that reticulocytes released prematurely from the bone marrow take longer to mature in the bloodstream. So this maturation time increases in anemia, so the RPI provides a more accurate assessment of bone marrow erythropoietic activity. For the calculation, once again, it is found on the slide. The maturation correction factor depends on the patient's hematocrit level. For an erythrocyte sedimentation rate, or an ESR, this is often ordered alongside other laboratory tests to help detect and monitor the course of inflammatory conditions such as rheumatoid arthritis, infections, and certain malignancies. It is a nonspecific marker of inflammation, though. For the principle, so this test uses the modified Westergren methodology, where blood is placed in a tall, narrow tube. The height of the column is sedimented red blood cells, is measured after a specified time, and that's usually about 1 hour, although there are some out there now that are 15 minutes. Just kind of depends what you got at your work. The taller column height allows for better detection of highly elevated sed rate values, which can indicate significant inflammation. There are a lot of sources of error with this test, though, such as improper sample collection or handling, temperature variations, patient factors such as anemia or polycythemia, and also the risk of contamination or clotting in the sample. There are some disposal kits, so specific kits are available for safe disposal of blood and reagents after testing to prevent the contamination and infection. There are also automated methods now, so the automated sed rate analyzers use a photometric or other techniques to provide rapid and standardized sed rate measurements, and this reduces manual errors and improves reproducibility. For point of care testing in hematology, so point of care testing involves diagnostic testing performed at or near the site of the patient, enabling rapid clinical decisions. This approach is increasingly used in hematology for quick assessment of the blood parameters. So point of care testing includes tests that are classified as waived or moderately complex, meaning they require minimal technical expertise and equipment, but still need proper oversight. So to ensure reliability, point-of-care testing programs must include clear administrative responsibility to manage testing processes, well-written procedures and protocols, consistent quality control to manage or monitor performance, participation in proficiency testing to validate operator competency, and routine equipment maintenance. Some common hematology point-of-care testing is we have hematocrit measurement, hemoglobin concentration, cell and platelet counts. These tests are essential for quick evaluation of anemia, bleeding disorders, and any other hematologic conditions in various healthcare settings.